Hello, everyone. My name is Mohit Agarwal, and I'm from the Medical College of Wisconsin in Milwaukee. And I'm joined here today by Dr. Larry Ginsberg from MD Anderson Cancer Center. And it is our pleasure to welcome you to the 8th episode of this amazing educational webinar series organized by the American Society of Head and Neck Radiology. Big shouts to Dr. Glastonbury, Dr. Robson, and other members of the Educational Committee of the ASHNR for putting together this great webinar series. This series has seen an amazing response, not only from the country, but from around the world. And we have attendees today from around the globe, including from Canada, Mexico, from several parts of South America, Europe, the Middle East, many parts of Africa, Southeast Asia, and Australia. And it is indeed my privilege to greet all our guests, and I extend you all a very warm welcome on behalf of the ASHNR. I want to remind you of the ASHNR 2020 annual meeting, which is scheduled from September 9 to September 13th. For those of you who have not registered for the meeting, here we have a link. You can use this to go online and register for the meeting, or you can also use this QR code. I always look forward to this meeting every year. It is a great meeting with great educational content, wonderful speakers. So if you have not already registered, please register for the meeting. It's always a great one. And what's better this time is that the meeting is virtual, which means that you can enjoy the meeting from the comfort of your home. All you have to do is register. I also want to encourage you all to become a member of the American Society of Head and Neck Radiology. It is a wonderful society, very welcoming. It is a very friendly society, very collaborative and cohesive. So if you're not already a member, please send in your memberships. As a junior member, I always congratulate myself for being a part of this society. So please become a member. Some housekeeping points before we begin. You will see two panels on your screen. One is a QA panel on which you can ask questions from the speakers. We take note of these questions, and at the end of the session, the speakers are going to address these questions and give you their unique insights and perspectives. There's another panel, which is called the chat box, in which you can do a little conversation with your fellow attendees. If you do not, however, want to see the chat box, you can always minimize it. Then this webinar has 1 CME credit, which you can claim by going to the ASNR Education Connection website. You can use this link, the asnr.mycrowdwisdom.com, and claim your CME credit. It will ask you to log in. If you're already not registered, you can create a login and get your CME credit. We have 2 more upcoming webinars before our annual meeting between September 9 and 13th, which were scheduled for August 20 and August 27th. Again, great topics and wonderful speakers, so you should take benefit from these free webinars. All you have to do is register, so remember to register. You can also view these webinars. They're always recorded, so you can go to the ASNR Education Connection website to see the recording once you've registered. After the annual meeting on September 22, we have our first European Society and American Society joint webinar, so stay tuned for that as well. Finally, for today's webinar, neither the speakers nor the moderators have any disclosures. The learning objectives for today's webinar are discuss the unique clinical and imaging features of nasopharyngeal carcinoma, review the AJCC 8th edition updated staging system for nasopharyngeal carcinoma, evaluate the role of EBV and immunosuppression in the development of lymphoproliferative disorders and lymphoma, and illustrate head and neck imaging findings of lymphoma in immunocompromised patients and how these can differ from those in immune competent patients. Finally, it is my honor to welcome and introduce our 2 outstanding speakers for today, Dr. Nancy Fischbein and Dr. Laurie Loevner. Those of you who have heard them know how outstanding and stellar speakers they are. Dr. Nancy Fischbein will be talking about the topic nasopharyngeal carcinoma staging and more. And Dr. Laurie Loevner will be speaking on the topic EBV Associated Lymphoproliferative disorders. Our first speaker, Dr. Nancy Fischbein, is a professor of radiology at Stanford University, originally from Boston. Dr. Fischbein, in her own words, is forever grateful that she made the cross-country trek out to San Francisco to train at UCSF under the phenomenal mentorship of Drs. Bill Dillon, Jim Barkovich, Alisa Jean, and others. After completing her residency and 2-year neuroradiology fellowship at UCSF in 1996, Dr. Fischbein joined the UCSF faculty and then subsequently moved to Stanford in 2004. Dr. Fischbein has a passion for clinical neuroradiology, and she enjoys nothing more than reading cases with trainees and participating in clinical conferences and tumor boards. She has served previously as a senior editor for ASHNR, and she's serving currently as the vice president of ASHNR. Our next speaker, Dr. Laurie Loevner, is the chief of the Division of Neuroradiology at University of Pennsylvania Health System, where she's a professor of radiology, otolaryngology, head and neck surgery, neurosurgery, and ophthalmology. Dr. Loevner is also the co-chair of the Academy of Master Clinicians of UPenn. Dr. Loevner is the past president of ASNR, ASHNR, and Eastern Neuroradiological Society, and is the co-chair of the foundation of ASNR. In 2012, she received the French-Canadian Radiological Society Prize of Innovation and Excellence of Dr. Jean A. Venzia for innovative body of research in head and neck MR imaging. And at our own 2019 ASHNR meeting, she was awarded the Society's gold medal. So without much further ado, I want to welcome our first speaker, Dr. Nancy Fischbein.
Hello, and welcome to today's installment of the ASHNR webinar series. I'm Nancy Fischbein from Stanford University, and I'll be speaking to you about nasopharyngeal carcinoma, staging, and more. I have no disclosures. I would like to thank all of you for being here. I'd like to thank ASHNR Education Committee Chair Christine Glastonbury for organizing this series, and I'd like to thank Debbie Schatzkes, Callie Robeson, and Alona Schmalfus for their tireless leadership of ASHNR during difficult times. My objectives are to discuss the unique clinical and imaging features of nasopharyngeal carcinoma, to review the AJCC 8th edition updated staging system for NPC, and to consider case examples for pearls and pitfalls. The nasopharynx is the uppermost part of the upper aerodigestive tract, shown here in 3 planes of T1 weighted imaging by this blue star. When we look at axial images, we want to pay attention to the eustachian tube orifice, the torus tubarius, and the fossa of Rosenmuller. Posteriorly, we look at the prevertebral muscles and also the clivus, shown to better advantage on the sagittal T1, which also well demonstrates the craniovertebral junction, the floor of the sphenoid sinus, and the pons and medulla posteriorly. Superiorly, or more superiorly, we also have the sella turcica and the optic chiasm, as well as cavernous sinuses and cavernous carotid arteries, Vidian canal on either side, and foramen rotundum, including V2. Lesions of the nasopharynx can be subtle and symptoms can be vague, things like headache or oral fullness. So that unfortunately gives us a lot of opportunity to miss incidental cancers or other lesions of the nasopharynx. So it's very important to include the nasopharynx in your search pattern for MR brain, MR cervical spine, or any other imaging study that includes the nasopharynx but is not necessarily specifically dedicated to it. With regard to nearby anatomy, the nasopharynx is an anatomically complex region. We always want to assess our adjacent fat planes, ideally on 3 planes of T1 weighted imaging. We want to consider cranial nerves and carotid arteries. We want to look carefully at skull-base foramina, and we do typically give gadolinium-based contrast agents, though much of our analysis in patients with nasopharyngeal carcinoma does not hinge on gadolinium. Here are 3 axial T1 weighted images from a patient with nasopharyngeal carcinoma. As we move superiorly in this patient, we can see that this tumor has extended to involve the pterygopalatine fossa and the Vidian canal. You can see the normal Vidian canal on the contralateral side. Tumor has extended back to foramen lacerum and the level of the horizontal segment of the petrous carotid. And then tumor has tracked superiorly along the carotid artery to the level of the cavernous sinus. So very important to use our T1 weighted images to analyze our anatomy, look at fat planes, and assess the extent of disease. With regard to the epidemiology of nasopharyngeal carcinoma, this is a malignant epithelial carcinoma that has a distinct epidemiology and histology. It has a high prevalence in southern China and Southeast Asia, as illustrated by this map, a 10 to 20-fold increase over non-endemic regions. There are two major histological subtypes, a non-keratinizing that can be divided into differentiated or undifferentiated, and then a keratinizing type. The Epstein-Barr virus is consistently associated with non-keratinizing nasopharyngeal carcinoma, and of these tumors, undifferentiated is the most common subtype and has a better prognosis. With regard to oncogenic viruses in nasopharyngeal carcinoma, in endemic regions like Southeast Asia, there is a very strong association with the Epstein-Barr virus. In non-endemic regions, there's an increasing recognition of a possible role for the human papillomavirus, but this has not yet been well worked out as it has been for oropharyngeal carcinomas. But with regard to prognosis, the EBV positive tumors have the most favorable prognosis, followed by the HPV positive tumors, followed by those that are EBV negative, HPV negative, which have the worst prognosis. With regard to staging, nasopharyngeal carcinoma is staged clinically because it is non-surgical disease. Surgery to the primary site or the neck is only used for persistence or recurrence. So unlike some other sites in the head and neck, like oral cavity, for example, there is no pathological or P staging. We rely on physical examination and imaging, typically a combination of CT, MR, and PET, to evaluate our patients and stage them. Therefore, it's especially important for the radiologist to know where to look and to know what's important. When we have a tumor in the nasopharynx, we're going to be looking for parapharyngeal space extension, extension to the prevertebral muscles, extension to the skull base. When we're staging nodes, we're going to look very carefully at the retropharyngeal region and the low neck in order to appropriately stage our patients. With regard to defining the primary tumor, this is a busy chart that is included for your reference, but we're going to go through examples from T0 to T4. T0 means that no primary site is found, but there are EBV positive cervical lymph nodes present. This is a 44-year-old man with a new right neck mass. You can see it here in level 2, mixed cystic and solid. When we look at his nasopharynx and skull base on the sagittal T1, it looks normal. When we look at an axial T2 weighted image, we can see that his adenoidal tissue is somewhat full, but it's striated, it's symmetrical, there's no obvious primary site on the MR imaging. When the patient had his node fine needle aspirated, it was positive for malignant epithelial cells that were P16 negative, but EBV positive. So MR, PET, and endoscopy were all negative in the nasopharynx. Therefore, he was staged as T0 unknown primary, but presumed nasopharyngeal origin based on the EBV positivity. A T1 tumor is confined to the nasopharynx, or it extends to the oropharynx and or the nasal cavity, but does not have parapharyngeal extension. Here's a patient who was undergoing workup for neurological issues, and his MRI demonstrated an incidental nasopharyngeal mass. On T1, T2, and post-gadolinium images, we can see a tumor that is expanding the right fossa of Rosenmuller as compared with the normal left fossa, but there is no extension beyond the nasopharynx. This lesion was also avid on FDG PET-CT, and the patient also had some enlarged abnormal retropharyngeal lymph nodes that I'm not showing you, but this was an incidental pickup on a study obtained for another reason. A T2 tumor has parapharyngeal extension and or extension to adjacent soft tissue, be it the medial or lateral pterygoid muscle or the prevertebral muscles. And this is a significant difference between the 7th edition AJCC staging and the 8th edition. In the 7th edition, the area outlined in yellow was our T2 tumor category. In the 8th edition, this has been expanded beyond the parapharyngeal space to include prevertebral muscle, medial, and lateral pterygoid. Here are two different patients with T2 tumors. This patient on the top has a rather large mass of the nasopharynx. When we look at the fat planes on the right and compare the left, we can see that the fat planes are infiltrated, and this is parapharyngeal extension beyond the buccopharyngeal fascia, which we'll talk about more in a moment. This patient has a somewhat smaller tumor, but nonetheless, when we compare the imaging appearance on the left with the right, we can see that this tumor is extending out laterally into the parapharyngeal space, infiltrating the fat planes that we can see on the left. Both of these patients have T2 disease. So parapharyngeal extension, by definition, is beyond the middle layer of deep cervical fascia, which is shown in this purple line from this nice diagram from StatDX. And this is just another diagram, if you want to look in more detail, demonstrating our mucous membrane, our constrictor muscle, and our buccopharyngeal fascia. So the middle layer of deep cervical fascia serves as a relative barrier to lateral spread and tends to direct tumor upward. The buccopharyngeal fascia, as mentioned, is a portion of the middle layer, and it invests the pharyngeal constrictors. The pharyngobasilar fascia is the aponeurosis of the superior constrictor muscle, and superiorly, the pharyngobasilar fascia and buccopharyngeal fascia blend together. These fascia attach to the skull base, lateral to foramen lacerum and medial to foramen ovale, and that, again, tends to direct tumor superiorly. However, the sinus of Morgagni is a gap that allows the eustachian tube and the levator veli palatini muscle to traverse these fascial layers on their way toward the pharynx, and this is a site that does allow tumor to extend out laterally into that laterally located parapharyngeal space. And here's just an example on a coronal T1 weighted MR image showing you that levator veli palatini muscle as it extends from the petrous portion of the temporal bone toward the palatine aponeurosis, and along the way, it passes through the sinus of Morgagni in order to breach that fascial layer heading from the skull base toward the pharynx. T3 tumor implies, or by definition, is infiltration of bony structures at the skull base or cervical vertebra, pterygoid structures, or the paranasal sinuses. Here's a patient who presented with left ear fullness. We see that he has the classic picture of a nasopharyngeal mass associated with a mastoid effusion. On this axial image, one could think that he might just be a large T1 tumor. However, when we look at a coronal T1 weighted image and compare the normal fat in the pterygoid body, the pterygoid process of the sphenoid bone, to the left side, we can see that the normal fat is missing, and this patient actually has a large tumor that has infiltrated the skull base. This is T3 disease. This is skull base involvement by a superiorly directed tumor, and those multiple planes of T1 weighted imaging are helpful, as some of these changes are actually quite subtle and can be very difficult to pick up, in particular on axial imaging. With regard to T4, these are large tumors with intracranial extension. They can have involvement of cranial nerves, hypopharynx, orbit. These are big tumors. 72-year-old man we have here who went to the ophthalmologist complaining of diplopia. An MR was ordered. We see a mass in the nasopharynx that has grown into the sphenoid sinus, infiltrated the clivus and the retroclival dura. In addition, on these axial pre- and post-GAD images, we see subtle and obvious extension to the cavernous sinus. By definition, the clival involvement alone might just be a T3, but the dural infiltration, the cavernous sinus involvement, this patient has T4 nasopharyngeal carcinoma. With regard to nodal staging, similarly, I've included this chart for your reference, and we'll look at examples of N1 through N3 disease. I also want to mention that extranodal extension is not part of NPC nodal categorization in the current staging system. It's possible that might change in the future, but at present, even though you might be asked about it at tumor board, it is not part of the staging for nasopharyngeal carcinoma. N1 nodal disease is unilateral cervical nodal metastases and/or uni or bilateral metastases in retropharyngeal lymph nodes that are less than or equal to 6 cm, and above the caudal border of the cricoid. Here is a patient who has a relatively small nasopharyngeal tumor, but there is metastatic adenopathy in right retropharyngeal nodes as well as cervical nodes, but his left cervical nodes look normal. And on his PET scan, again, we see retropharyngeal and right cervical lymphadenopathy with nothing lighting up in the left neck. This is N1 disease. N2 disease is bilateral cervical lymph nodal metastases. Again, they have to be less than or equal to 6 centimeters and above the caudal border of the cricoid cartilage. This patient has large bilateral retropharyngeal nodes, but also bilateral pathological cervical lymph nodes. This is N2 disease. N3 disease is large and low. Here we see a patient with a large nodal mass. It's greater than 6 centimeters. This particular node is greater than 6 centimeters, but even more importantly, we're well below the caudal margin, caudal border of the cricoid cartilage, and this patient has extensive cervical adenopathy low in the neck. This is N3 disease, and this is a poor prognostic feature. With regard to metastatic disease, involvement of lymph nodes below the clavicle equals distant nets. So if all this patient had was a relatively small primary, bilateral retropharyngeal nodes, bilateral cervical nodes, and a hilar node, this hilar node still constitutes distant metastatic disease. But this patient, unfortunately, has a lot more than just that. The most common non-nodal metastases in NPC are to bone, lung, and liver. Synchronous distant metastases are present at the time of presentation in endemic nasopharyngeal carcinoma in 5 to 10% of patients. The 5-year distant metastatic rate for low-risk patients is about 5%, and for high-risk patients is on the order of 30%. As we mentioned, nasopharyngeal carcinoma is treated with radiation, potentially the addition of chemotherapy, and an evolving role for immunotherapy. Early on, when patients are treated, we see edema and mucositis. Later, we see fibrosis and scarring leading to the featureless appearance of the nasopharynx. Signal abnormality may persist for quite some time in soft tissue and marrow. If it's stable, it's usually granulation tissue or fibrosis, and that's typically fine. But if it's progressive, you want to think about recurrent tumor, but you also want to think about radionecrosis and/or infection. Here's a patient with T1, N1 nasopharyngeal carcinoma who had a great response to chemotherapy. We imaged the patient a year and a half later. When we look at the MR and the PET, you would barely know that the patient had been previously treated. We do see some inflammatory paranasal sinus mucosal disease, which is common following radiation, and one could argue that the patient has a little bit of a featureless or fibrotic appearance to the nasopharynx. We don't see those normal contours that we expect. Here's a patient, a 20-year-old woman, who was treated for nasopharyngeal carcinoma. Here we see her initial exam, and shortly after she completed her initial round of therapy, we see inflammation and mucositis, but things are looking much better. This intermediate sort of gray tumor has resolved. We now see this brightly enhancing mucosa. The contours of the nasopharynx look relatively normal. But when we scan this patient 15 years later, we can see that she looks fibrotic. The fossa of Rosenmuller is essentially obliterated. The eustachian tube orifice is no longer so distinct. This is the featureless nasopharynx. Now, some of our patients may have relatively circumscribed or limited recurrences, and I want to introduce you to the possibility of an endoscopic nasopharyngectomy. This is considered for patients who are post-primary treatment who have recurrent tumor that is typically RT1, maybe RT2. Now, these patients could be re-irradiated, but this increases the risk of radiation necrosis. So surgery can be considered for resectable recurrent tumor that is RT1, maybe RT2, because this is less morbid than re-irradiating with intensity modulated radiation therapy or stereotactic radiosurgery. Here's a young woman with headache, epistaxis, ear fullness. She's got a large nasopharyngeal tumor. She's got retropharyngeal lymphadenopathy and a mastoid effusion. She gets treated with chemoradiation, and then 2 years later, on a routine follow-up, we detect an asymptomatic recurrence in the left nasopharynx. She goes on to have a endoscopic nasopharyngectomy. You can see that she is missing the posterior aspect of her nasal septum now. The tumor is gone, and we've been following her for many years, and she has remained free of disease, no evidence of disease on follow-up. So endoscopic nasopharyngectomy can be very helpful in the right patient. There are many treatment-related complications that we need to be on the lookout for. We may see temporal lobe radiation necrosis. This was more common in the old days before IMRT, but we still sometimes see it, especially with patients who were treated many years ago. We might see osteoradionecrosis that can occur in the clivus. It can occur at the craniovertebral junction, as shown here. It can involve the temporal bone. Many locations can be involved with osteoradionecrosis. This patient has skull-base osteoradionecrosis, also involvement of the temporal bone, and you can see that this has been complicated by a large mastoid abscess. This patient has a radiation-induced fibrosarcoma, and this patient has a high-grade ICA stenosis related to prior high-dose radiation therapy. So these are some of the things that you want to be on the lookout for in follow-up. Here's a patient, a 64-year-old lady who was treated for NPC 10 years earlier. She's 64 years old, and this was a routine follow-up MR. She had no acute issues. She did have chronic mastoid effusions, but her vessels, her sinuses, her orbits, everything was looking pretty good. She does have some T2 hyperintensity in her central pons. 10 months later, she developed diplopia and increasing epistaxis. CT was interpreted as concerning for recurrent tumor, and an MR was, of course, suggested. You can see she's got some bone erosion and opacification of the sphenoid sinus. On her MRI, which was obtained 3 days later, she has some nonspecific soft tissue within her sphenoid sinus, but also this funny rounded area that's immediately adjacent to her petrous carotid. This was interpreted as recurrent tumor, and she was referred semi-electively, as opposed to emergently, to rhinology clinic. She then gets seen in rhinology clinic, and following her visit, as she's out in the parking lot, she exsanguinates from a right ICA pseudoaneurysm, and this is a pseudoaneurysm. This is an uncommon complication of radiation therapy for nasopharyngeal carcinoma, but it has been reported. And this case is really just a reminder to think about vessels in post-RT follow-up imaging. You don't necessarily have to do a dedicated MR angiographic sequence. We do actually a cube T1 weighted image, which is a black blood image that gives us a nice look at the vessels. But whatever imaging sequences you're using, please look at the vessels, be sensitive to carotid stenoses, as I showed you earlier, and be sensitive to the possible development of pseudoaneurysm, especially in association with infection or soft tissue or bony radionecrosis. Here's a patient, 82 years old, treated for nasopharyngeal 20 years earlier. She has an MR for worsening pain, occasional oral bleeding, and halitosis. And we see multiple sites of osteonecrosis, maybe osteomyelitis, involving her clivus, her hard palate, and her mandible. She also has chronic maxillary sinus disease. She was started on antibiotics and told to follow up. 7 months later, she's got progressive pain and bleeding. We see a large mass involving her hard palate in the sagittal, axial, and coronal planes. She was felt to be unresectable for various reasons. She was a very poor surgical candidate. Her biopsy showed a poorly differentiated EBV negative squamous cell carcinoma, and she was treated with palliative radiation therapy. In this particular case, on the earlier imaging, this focal mass was hiding in plain sight, but very difficult to detect against a background of severe radionecrosis and osteomyelitis. So in summary, we've talked about the basics of NPC, a little bit about the epidemiology, reviewed the staging, gone through imaging examples of the various T and N categories. We've talked a little bit about post-treatment appearance and pitfalls. Remember vessels, be on the lookout for recurrence, be on the lookout for complications. And with that, I thank you very much for your attention today, and I'm happy to answer any questions. Thank you.
Hey everybody, it's my pleasure to be with you to talk about Epstein-Barr virus-associated lymphoproliferative disorders. I'd like to thank Christine Glastonbury and the whole ASHNR team for their years of support and friendship. I'd also like to thank my friend and colleague, Nancy Fischbein, who will be my partner in crime today. So today we're going to review the epidemiology and the biology of Epstein-Barr virus and its role in developing lymphoma. And then we will spend some time looking at images in patients with EBV-associated lymphoma. We heard Dr. Fischbein talk about nasopharyngeal cancer and the etiologic role that Epstein-Barr virus plays in these tumors. And today I'll be talking about the role of Epstein-Barr virus and immunosuppression in the development of head and neck lymphomas. So we all know that Epstein-Barr virus infects more than 90% of individuals worldwide. In developing countries, infection occurs typically in infancy with a mild viremia, whereas in developed countries, infection typically occurs in adolescence and early adulthood. This usually presents as a benign, self-limited lymphoproliferative disorder with flu-like symptoms known better to all of us as mononucleosis. There are 9 latency-associated Epstein-Barr virus proteins. These target cellular functions and lead to genomic instability, which is the hallmark of malignant transformation. You can have clonal chromosomal aberrations that deregulate the expression of oncogenes or tumor suppressor genes, or you may have non-clonal chromosomal aberrations, such as abnormal repair of DNA breaks. So our immune system and how it responds to Epstein-Barr virus. The virus gets into our B lymphocytes, which results in a vigorous lymphocyte proliferation. That in turn stimulates a very vigorous cytotoxic T cell response against most viral latent proteins. And this allows us to eliminate most of the EBV infected cells from our system. And each of us has some latent EBV peripheral lymphocytes. Now, we all know that there's persistent infection in well over 70% of adults worldwide, yet we know there's an extremely low incidence of Epstein-Barr virus tumors compared to the marked prevalence of infection. And this lets us know that the virus is but one step in a multi-step process in going on to be able to develop tumor lines. We heard Dr. Fischbein talk about Epstein-Barr virus in conjunction with genetic, environmental, and immune factors that may contribute to cell alteration and the development in nasopharyngeal cancer. And today we're going to see how simply immunosuppression in association with Epstein-Barr virus may result in lymphoblastoid transformation of lymphocyte lines and lead to lymphoma. So in culture, Epstein-Barr virus infected B cells transform to lymphoblastoid cell lines if we remove the T cells or we inhibit the T cells. What this implies is that in order to prevent B cell tumors in vivo, we need to have an intact immune system. We also know that in therapy-induced, immunosuppressive therapy-induced lymphomas, that we see many of these tumors regress if we reduce immunosuppression. So in immunocompromised patients, there are 3 types of Epstein-Barr virus-associated lymphoproliferative disorder. These include post-transplantation lymphoproliferative disorder, seen in the setting of immunosuppression, AIDS-associated lymphoproliferative disorder, and a spectrum of lymphoproliferative disorders seen in inherited immune deficiencies. So let's start with post-transplantation lymphoproliferative disorder. We will call that PTLD. This ranges from benign lymphoid hyperplasia to lymphoid neoplasms, including lymphoma. This occurs following organ transplantation, and the EBV infection may originate from the donor, in which case the infection is acute, or the EBV may originate from the recipient, in which case the infection is reactivation. If the transplant recipient is seronegative prior to transplantation, this increases the risk of developing PTLD. And if you look at all transplant recipients together, the frequency of PTLD ranges from 1 to 10%. Now, the development of PTLD is directly related both to the degree and the duration of immunosuppressive therapy. The more potent the cocktail, the longer you're on it, the more likely you are to develop PTLD. And you'll see that there are organ-specific regimens. So the kidney, which has a relatively mild immunosuppressive regimen, those recipients have about a 1% chance of developing PTLD, compared to heart and lung transplant recipients who are on a much more potent immunosuppressive regimen. And their incidence of PTLD is 3 to 8%. And in bone marrow transplant recipients, the incidence of PTLD can be as high as 10%. And again, this PTLD is due to loss of the cytotoxic T lymphocytes, which allows EBV-driven unregulated B-cell proliferation. You may develop PTLD as soon as months following transplantation or years after transplantation. And it's important to recognize that if untreated, PTLD is usually fatal. The World Health Organization classification identifies early onset PTLD, which is an EBV-driven polyclonal disorder, compared to late onset PTLD, which is a true monoclonal disease, and this is when we get Burkitt's lymphoma, B-cell lymphoma, and Hodgkin's disease. Now, there is a T-cell PTLD. This is very rare. It occurs many, many years after transplantation and is usually very, very aggressive and fatal. And it's important to recognize that T-cell PTLD is not associated with the Epstein-Barr virus. So PTLD, let's talk a little bit about the clinical presentation. PTLD, and in fact, lymphoma developing in all immunocompromised patients, is the great masquerader. And what do we mean by that? Well, these patients tend to present with systemic symptoms that mimic mononucleosis or a flu. They get fever and fatigue and sore throat and lymphadenopathy. And these may be mistaken for infection, and it may take a while for people to think about the diagnosis of a lymphoma. These patients may present with lymphoid tumors that involve the extranodal sites or the cervical lymph nodes in the head and neck. And it's important to recognize that extranodal sites are more common than cervical lymph nodes and may involve the central nervous system, Waldeyer's ring, the paranasal sinuses, or the orbit. Now let's start with our first great masquerade. So this is a 56-year-old transplant recipient who's immunosuppressed, comes in with multiple neurologic complaints over weeks, including transient visual loss, tingling in the hand, and intermittent droopy face. The working clinical and radiologic diagnosis was stroke. And here you'll see the patient's initial MRI. You'll see a large area of signal abnormality in the right centrum semiovale and corona radiata. And within this, you'll see a smaller area of restricted diffusion, this very dark area right here. The patient was observed and sent home, and 6 weeks later came back with recurrent waxing and waning neurologic symptoms. And here you see interval enlargement of that original lesion in the right corona radiata and centrum semiovale, as well as interval development of multiple new lesions in the gray-white matter interface, in the deep white matter, and in the cerebellum. The patient was called back for contrast, and here you'll see enhancement in some of these gray-white matter lesions. You'll see enhancement in the medial left occipital lobe, and very important, enhancement along the folia, the leptomeninges of the cerebellum. And this should make you think about other infectious disorders and other neoplastic disorders, and especially B-cell lymphoma in the setting of immunosuppression. The patient should get a systemic workup, and here you'll see the abdomen CT of this patient, where there are multiple nephratic masses in the renal fossa on the right that were biopsied and consistent with B-cell lymphoma. So going back and looking at the patient's original MRI, again, this region of signal abnormality in the right centrum semio-valley, and the smaller area of restricted diffusion. Now remember, this area of restricted diffusion is much smaller than the surrounding T2 signal abnormality, and that additional T2 signal abnormality that is not restricting, you should think about an element of superimposed vasogenic edema and other diagnoses and infections, including lymphoma. So the take-home points from this particular patient in the central nervous system is that in immunocompromised patients with suspected syndromes of recurrent stroke, please consider getting enhanced MRI, and you should consider lymphoma. You should have that on your brain. But when you see these additional imaging findings, you should really have lymphoma in the forefront of your head. If you see regions of T2 signal abnormality that are markedly larger than the area of restricted diffusion, think about lymphoma. If you see enhancement in subacute and acute lesions, think about lymphoma. And if you see multifocal areas of leptomeningeal enhancement, think about lymphoma and do a systemic workup. Here is a patient with B-cell lymphoma following renal transplantation. The patient was managed with reduction in immunosuppression, and here 6 months later, you can see the marked regression in the size of these lymphoid tumors. This is a different 40-year-old patient following liver transplantation, and you can see signal abnormality in the right periatrial white matter extending into the white matter tracts of the corpus striatum, and following contrast, we see this feathery enhancement along the perivascular spaces, and again in the coronal plane, consistent with B-cell lymphoma. Now, when we look at lymphoid involvement of PTLD and other immunosuppressed conditions in the neck, we want to look for extranodal masses, and these typically occur in Waldeyer's ring, but they may involve any of the soft tissues of the neck. And it's important to remember that 50% of the solid masses are hypointense on T2 weighted imaging relative to CSF. This means they follow the signal characteristics of brain and typically have restricted diffusion. And 50% of the masses in the neck are going to be necrotic, and they are frequently misinterpreted as an abscess. It's important to denote that in immunocompromised patients, it's uncommon to see necrotic masses related to lymphoma. Lymphoma in immunocompetent patients only has about a 2 to 4% incidence of presenting as a necrotic mass, compared to immunocompromised patients where the presence of necrotic masses is approximately 50%. So here are 3 different patients with markedly enlarged bilateral palatine tonsils, all kissing in the midline of the oropharyngeal airway. Biopsy is necessary because the lymphoid lesions, ranging from benign to malignant, may have similar imaging appearances. Patient 1 has B-cell hyperplasia, patient 2 plasmacytoid hyperplasia, and patient 3 has B-cell lymphoma. This is a patient that developed dysphagia, and here you can see a large mass along the lingual tonsil projecting into the vallecula here and resting along the lingual surface of the suprahyoid epiglottis. This was biopsied and represented benign lymphoid hyperplasia. And look at this B-cell lymphoma masquerading as an abscess. Here's a large necrotic mass in the paraspinal region. You can see some mild extension into the epidural space, and this was misdiagnosed as an abscess for approximately 6 weeks. This is B-cell lymphoma, and one of the things that helps to distinguish it from an abscess, or at least should raise suspicion that maybe it's a tumor, is that given the size of this large necrotic mass, there is relatively little edema in the surrounding paravertebral tissues, and you can see still preservation of the fat planes between the different muscle fascicles. This is a different patient that was misinterpreted as an abscess for about 8 weeks, and here you can see a necrotic mass in the left nasopharynx, and this also was B-cell lymphoma in the setting of bilateral lung transplantation. When we look at nodal disease from lymphoproliferative disorders in the setting of immunosuppression, these nodes may be bilateral, they may involve all nodal basins, the nodes may be numerous and normal in size, but seen in multiple clusters, so too many of them, even though they're normal in size, and you may get one large nodal mass. That mass may be solid or it may be necrotic, and again, if necrotic, it may mimic an abscess. Here is a patient with multiple normal-sized nodes in clusters, this one in the base of the left neck, and here they have a cluster in the posterior triangle on the right, and here you'll see a small nodal mass in the anterior mediastinum in the thymic bed. These are two different immunosuppressed patients. This patient's 9 years after heart transplant, and we see a large solid mass in the right neck consistent with B-cell lymphoma. And this is a different patient with AIDS who has B-cell lymphoma in the left neck, a very aggressive looking mass. It's occluding the internal jugular vein. It's extending into the sternocleidoid mastoid muscle. This was treated for 6 weeks as MAI because they had MAI in their lungs, but on biopsy, it was finally identified to be B-cell lymphoma. Now, moving on to the sinonasal cavity and post-transplantation lymphoproliferative disorder. This is the mimicker in the sinonasal cavity. Lymphoma and fungus look the same. PTLD may mimic fungal sinusitis clinically and in many ways radiographically. It is frequently associated with bone destruction, extra sinus extension. Again, the masses tend to be iso-intense to brain. They have restricted diffusion, and they may have solid or peripheral enhancement. Here is a patient with a solid T2 iso-intense mass, right, similar to brain. It extends into the orbit here in the extraconal fat and abutting the muscle cone, and we see some solid enhancement along the periphery, and the central area has no solid enhancement. And here you see the restricted diffusion on the ADC map. This is a different patient that has chronic sinusitis in the sphenoid. We see this long-standing neoosteogenesis, but they develop destruction of the lateral and the superior wall of the sphenoid sinus. And here we see lymphoma filling the sphenoid sinus. Here it is very cellular, iso-intense to brain on T2 weighted imaging. We see edema in the clivus, a lymphoid mass in the nasopharynx, and extension of the lymphoma into the bilateral foramen rotundum. Let's look at this patient with sphenoid sinus opacification. Here you see destruction of the superior and inferior wall of the sphenoid sinus. And here is the MRI. And this MRI shows that the tissue in the sphenoid sinus is markedly hypointense. It looks like air, but we know it's not air. The sinus is opacified. This is pathognomonic of fungus. Tissue in the sinus, iso-intense to air, is pretty pathognomonic of fungus, and the low signal intensity is due to high protein concentration, the presence of hyphae, and the presence of iron. So again, markedly hypointense, similar to air on T2 weighted imaging, may be very helpful in distinguishing lymphoma, which usually follows the signal characteristics of brain, from fungus. Like air, think fungus. Here's a patient with HIV and an Epstein-Barr virus-induced plasmacytoma. Here we see the diffusion and the corresponding ADC with restriction. The solid mass on T2, similar to gray matter. And here we see the solid enhancing mass in the sinus and the little biopsy tract. This is a different patient with a cluster of grapes appearance in the right maxillary sinus, iso-intense to brain, solid enhancement, and restricted diffusion. This is AIDS with B-cell lymphoma. And this is a Burkitt's lymphoma, iso-intense to brain on T2, marked bone destruction of the sinus wall, the zygomatic process, and the zygomatic arch, solid enhancement, and restricted diffusion. Moving on to orbital lymphoma in the setting of immunosuppression, orbital masses may be multiple or single. They have a propensity to involve the superior lateral quadrant of the orbit, which is most common, but the tumors may occur anywhere in the orbit. Importantly, they mold or conform to the shape of the space that they're in, and unlike the sinonasal cavity, bone destruction is uncommon. So here is a patient with two iso-intense masses, right, similar to brain on T2 weighted imaging. Here we see, comparing pre and post contrast, the solid enhancing nature of this mass in the superior eye along the muscle complex resulting in ptosis, and also in the lateral quadrant. And here we see the associated restricted diffusion of these masses. This is a patient with lymphoma involving the superior muscle complex, restricted diffusion, and here is the tumor along the muscle complex. And it's important when you identify intraorbital lymphoma to look for where it spreads. It may grow through direct growth, it may spread perinormal, and V1 would be most common because of the propensity for these lesions to occur in the superior lateral orbit. It may spread back to the superior orbital fissure and the cavernous sinus and other skull-based foramina. It may have subarachnoid seeding or systemic disease. So this is a patient with a large mass in the superior lateral quadrant of the right eye involving the subperiosteum and the bone, the right frontal bone. You see that it restricts on ADC and this solid enhancement. Look very closely, you'll see the lesion extends into the supraorbital foramen. And when you come to the imaging in the axial plane, not only does the supraorbital foramen allow tracking along V1, but because of the periosteum around the framing, you can get direct growth into the intracranial compartment. And here we see this large dural implant and the dural enhancement just above the roof of the orbit. And here you'll see some mild edema in the frontal lobe adjacent to this big dural implant. This is another patient with lymphoma. Look at it behind the eye in the retrobulbar compartment, conforming to the shape of the orbit, no bone destruction. Here you see extension to the superior orbital fissure, inferior orbital fissure, foramen rotundum, and the pterygopalatine fossa with associated restriction on diffusion weighted imaging. Look at this patient with bilateral retrobulbar intraorbital lymphoma conforming to the shape of the orbit, no bone destruction, and here we see perineural extension along foramen rotundum into Meckel's cave. And it's important to remember that the fluid in Meckel's cave communicates with the CSF in the posterior fossa, and here you see the subarachnoid seeding in the internal auditory canal, and it's actually making its way to the cochlea, and again, diffusion restriction on the ADC map. Treatment of immunosuppressed induced lymphoma. So lymphoma in the setting of PTLD and immunosuppression, the first thing they like to try to do is reduce immunosuppression to see if the tumors regress. They frequently give pulsed IV steroids, depending on whether you have systemic disease or a large nodal mass. You may get chemoradiation or just radiation. And then there's a whole spectrum of immune modulation and monoclonal antibodies, including cytotoxic T lymphocyte transfusions against EBV antigens. So, in summary, take-home points. Immunocompromised patients with systemic symptoms and head and neck pathology or lymphadenopathy, please think about lymphoma. Have a high index of lymphoma when you're thinking about fungus and other infections. Have lymphoma out there at the forefront. Testing should include tissue sampling, not just for infections, but for lymphoproliferative disorder. If it turns out to be lymphoproliferative disorder, you must do a systemic workup. That might be a chest, abdomen, or pelvis CT, or it may be a PET CT or both. Please remember that delayed diagnosis of PTLD and lymphoma in any setting of immunosuppression leads to a poor prognosis, and undiagnosed, this condition is usually fatal. Thank you all again for your time. I so enjoyed participating in this webinar. Thank you, Nancy, for your partnership, and Christine Glastonbury and the entire ASHNR.
Thank you so much to everyone. And Nancy and Larry, would you like to answer some of those questions live before you move on to the quiz?
I was told to do the quiz first, but you can, if you'd rather have the answers, let me know. It's okay.
Whatever works for you is good.
Let me just show the case real quick, and I think we will have a few minutes. So I'm Larry Ginsberg from MD Anderson, and this is the case that you got as a teaser. Hopefully you can see it. And the first point that I wanted to make was that there's this rind-like enhancement around the left internal carotid artery at the level of the cavernous sinus. And so what was the connection that got it there? Well, this tumor, this nasopharyngeal cancer spread submucosally to the level of the carotid canal just beneath the skull base, and then it went and used the carotid canal as a scaffold, if you will, and we have seen this in a few patients, and it can actually wind its way up the carotid canal, and in some of the cases we reported, this was the only intracranial extension of that particular cancer. So keep an eye out for that. And then the other connection I showed was this patient with a large nasopharyngeal cancer had a little linear tracer activity, and then quite a bit of tracer activity and markedly iso-intense or low signal in the middle ear and mastoids. How did that happen? Well, that happened because this cancer spread along the eustachian tube. Now, neither of these is an everyday spread pattern of nasopharyngeal cancer. They're both pretty uncommon, but this patient had both of them, so it can happen. And so up the eustachian tube and into the middle ear and mastoids, and that is the explanation for this abnormal signal. And there is some literature for this. So that is what I wanted to show. And I will now address the only two questions that we received to Dr. Fischbein. They both have to do with nasopharyngeal cancer. So Nancy, number one, if a nasopharyngeal cancer makes its way into the pterygopalatine fossa without obvious bone or sinus erosion, is that T3? And then the other question, and you can take them both, is whether or not osteoradionecrosis and osteomyelitis can be distinguished. Dr. Fischbein.
Thank you, Larry, and thank you so much to the attendees for posing the questions. So with regard to involvement of the pterygopalatine fossa, I actually had to laugh when I saw that great question, because that was something that I sort of hoped would be like explicitly laid out in the most recent version of the staging system, because it's something that I have struggled with myself. But I think my position is very similar to what Dr. Ginsberg noted when he wrote his reply to the question, which is for T3 staging, one of the involvements is, quote, pterygoid structures. And I find that when the pterygopalatine fossa is involved, that very often the pterygoid plates, the pterygoid process are also involved. And so I sometimes take a little bit of a punt there and I say, well, the pterygopalatine fossa is involved, but look, the pterygoid process is also involved. That's T3. Now, bumping up to T4, the easiest bump up to T4 is intracranial extension, because that's very straightforward in general. But T4 is also involvement of cranial nerves. So, for example, if tumor extends from the PPF along V2 in foramen rotundum, to me, that would bump up to T4. I have to admit, I struggle a little more with the Vidian canal. And I think you mentioned Vidian in your reply, Larry. So I'd be interested in your thought about that as to whether Vidian truly counts as bumping up to T4. But again, these are semantic, and maybe in the next edition of the AJCC staging, things will be more explicitly laid out regarding the pterygopalatine fossa. It really depends on whether there are studies showing that those things really make a prognostic difference. Because remember, that's why this transition to the new staging was made, because patients who fell into certain categories shared the same prognosis. So it's really all about patient treatment and prognosis, and not necessarily about parsing out all the fine points of imaging, much as we love those. So I don't know, Larry, what do you think about Vidian canal? You think that's T4?
I think it's a branch of a cranial nerve and thus cranial nerve involvement. And if I saw a definite Vidian canal, I would call it T4.
Mm-hmm. Okay. And then the other question about osteoradionecrosis and osteomyelitis, or to broaden that, it doesn't have to be osteo really, it can be soft tissue radionecrosis and soft tissue infection. My feeling about those is that, and similarly to Dr. Ginsberg's response, is that they so often go hand in hand that I find that when we discuss them at Head and Neck Tumor Board, we tend to just send the patient in the same direction, which is treating for both, which is often hyperbaric oxygen and antibiotics. Now, sometime, I suppose, especially with soft tissue, if one has a peripherally enhancing collection, one could argue if that is truly an abscess as opposed to just soft tissue radionecrosis, does that actually need to be drained? But typically, those are not intervened on upfront. We will put the patient to that same triage, which is hyperbaric oxygen and intravenous 6 weeks of antibiotics, and then see how the patient looks at the end of that time. I did also comment that we do sometimes apply nuclear medicine studies, but nuclear medicine studies tend to be sort of low res and non-specific. So one could certainly try something like indium white cells, but I really don't know that you're going to gain useful specificity by doing that kind of a study.
Okay, a couple more questions popped up. One of them is easy. It says, is it common to get radionecrosis of adjacent brain after radiotherapy of NPC? Yes, we see it all the time, most commonly in the anteromedial temporal lobe, but Dr. Fischbein, take it away.
Yeah, no, I agree with you. My only comment on that would be that in the past, before there was so much focus on IMRT, intensity modulated radiation therapy, we used to see a lot more temporal lobe radionecrosis. And I feel like now I see less brain and more skull base and adjacent soft tissue. So
Right.
I think it's less common than it used to be, certainly still happens, and I see a lot more skull base and adjacent soft tissues.
Right, that's probably true in nasopharynx. In other malignancies, sinonasal especially, it's very common to see inferior frontal lobe radiation necrosis, very common. The second question is for Nancy. In the case along cranial nerve 7, couldn't that have been perineural spread via the Vidian nerve? And geniculate ganglion via the GSPN. Now, we can't go back and pull up your case because the lecture was pre-recorded, but I thought I might have seen a Vidian case in there. So,
or was that to your case that you showed?
Oh, in the case along cranial nerve 7. My case didn't have cranial nerve 7. My case, oh, he's asking, so the question is, could this have been greatest superficial coming from there? Yeah, I suppose that would be pretty hard to exclude, except to say that, perineural spread along the greatest superficial petrosal nerve into the geniculate ganglion, it's pretty rare. We do see it. I've published it, but this business of filling the entire middle ear in mastoids really speaks to more common, to more likely eustachian tube spread. So I think that the question is not unreasonable, but I believe in this case, based on a totality of the findings, that it was more likely eustachian tube.
Yeah. Also, Larry, your case is really beautiful. And in this case, of course, there's a large mass and a lot of tracking along the carotid, but that little halo of tissue around the cavernous ICA on the T2 and the post-GAD image can be a lot more subtle sometimes. And I think that's a really useful finding. And thank you for all the things you have published that have been so helpful to all of us over the years.
Well, we're fresh out of questions. I think we're going to serve drinks now. Is that right, Callie? Is there drinks? Could we have some drinks now?
Maybe a knock on your door from DoorDash or something.
For sure.
Anyway, thank you to everybody that attended, and we hope you enjoyed this session, and we'll see you next week. Stay safe.
Thank you.
Thank you all. Thanks for
Bye.
excellent talks.
Thank you very much.
Thanks, Mohit.